right, so hi everyone, my name is Irene. I'm from Amsterdam, the Netherlands. And yesterday I already talked a little bit about what kind of clinical research we're doing in the Netherlands. It's solely observational, so we're not testing any new drugs or anything. But I'm going to share some preliminary results and also discuss the clinical care pathway that we're developing. We're looking at defining natural history. We want to be able to predict phenotype, and I mean we want to predict or earlier detect cerebral disease, and of course the development of the clinical care pathway. So let's start out with defining natural history. Why is that so important? Yesterday we've also been talking a lot about quantifying disease, quantifying myelopathy. So that means we want to give a number to the amount of disease someone has. But why? Why is that a problem? I have an example. So this is a male ALD patient I saw at our outpatient clinic in 2015 and 2016. It's a 43-year-old patient who has adrenal insufficiency, and the past years has shown a progressive myelopathy, and he has no cerebral disease. So when I ask this patient, how are you doing? He tells me, the walking has deteriorated. I'm getting worse. It's getting worse. I cannot walk as far as last year, and I'm having problems getting up the stairs. So I perform my neurological exam, and we start off with the motor function. We test the motor function by looking at the different muscle groups, and we give that a grade. So a grade of 5 would be the highest grade and mean there is no weakness, and a grade of 0 would be the lowest score and mean total weakness. And if you can see, it seems like the motor function improved in a year. And if we look at the sensation exam, at first, touch sensation was abnormal not only in the feet, but also the upper leg on the right side. In 2016, it was just in the feet abnormal. So the neurological exam improved. But the patient's telling us it's gotten worse. So what is the right thing? Did he get worse? Did he not get worse? And what if this patient had been in a clinical trial? Would we have said, oh, the medication's working because the neurological exam improved? It's really difficult, and this is a problem that we face. So that is why it is so important that we learn how to define and quantify this myelopathy. And how are we doing this? We're doing a really extensive neurological exam. We're looking at myelopathy scales. For instance, we're looking at the severity score system for progressive myelopathy, and this really combines different aspects. So it doesn't only look at the neurological exam, but it also takes into account the arm and leg disability. It looks at bowel and bladder function, and by combining these, you get a score that is supposed to quantify disease. Besides that, we're also looking at optical coherence tomography. So that means we're looking at the optic nerve. There are also a lot of axons in the optic nerve, and we want to see if that correlates with the disability in the rest of the body. And we're looking at spinal cord MRI. So besides the myelopathy, we're also doing a longitudinal follow-up study of women. Because in 2008, Mark Engele, he did a cohort study in 46 women and saw that, well, women are not merely carriers, they're patients. And now we want to see them again. We've almost seen all of them, and want to assess how these patients are doing. So if they were asymptomatic a couple of years ago, how are they doing now? Are they still asymptomatic? And if they were symptomatic back then, did they progress or not? I think that's really important information we need to collect. And besides that, we're doing the neuropsychological assessments in male patients without cerebral disease. Phenotype prediction. So we already talked about newborn screening. So many more patients are being diagnosed with ALD. And for boys, this means that they enter the spiral of MRI follow-up. And we need to be able to tell them more about if they're a high risk of developing cerebral disease or a low risk, so we can provide them with individualized care. How are we doing that? So current practice would be if someone visits our outpatient clinic that they would just get a regular MRI. We do some blood work for the endocrinologist. But if they enter our study, they get an extensive MRI. So it's quite a long MRI protocol. We do blood work for something that's called lipidomics, and I'll get into that a little later. And they get a lumbar puncture to get cerebrospinal fluid, also to look with the lipidomics. Is everyone still with me? No questions? All right. Sorry? Yes. We always give contrast. Yeah. Just to look into some of the first imaging results, we looked at just the first visit for 45 patients and just the regular imaging. And you can see here on the x-axis that it's the age of the patient. So the youngest was 3 and the oldest was 70. And on the y-axis is the LUS score. So this is the score for the amount of MRI abnormalities. The higher the score, the more abnormalities. And what we noticed that in 8 of our patients, we saw abnormalities similar to what we see in cerebral ALD. But what was the difference? These patients had been stable for years and years. They were diagnosed with lesions like this. So these are 2 different patients. This one's 37, this one 29, and they were diagnosed as children, and they already had these lesions. So this is not supposed to be there. And this does not show any gadolinium enhancement. But what is this? Did they have cerebral disease when they were children? And did it halt by themselves? It looks like that. So this was the case for 8 of our 45 patients, so 18%, which is very similar to what Florian also talked about yesterday. And further follow-up and analysis with some quantitative MRI techniques will hopefully reveal some new information on what these abnormalities are and what the prognosis is. So we do blood and CSF for lipidomics. Lipidomics is a technique so we can look at all different kinds of lipids. And we use this machine, and it's a mass spectrometer, and it means, it's a really fancy name for just saying we're weighing molecules. And we did our first experiment with blood of patients and some control subjects only a couple of weeks ago, so I have the very, very first results. And we used 20 microliters of plasma. So that's 0.02 milliliters. So that's a tiny amount. Try to imagine how small a milliliter is, and then even smaller than that. And we used the blood of 12 patients and 12 control subjects. And this gave us more than 10,000 data points. Does any of you ever work with Excel? Could you raise your hand so you know Excel? So imagine 10,000 data points. That's terrible. Yes. So when you have that much data points, you have to do something to be able to visualize data like this. And a way to do that is a Volcano plot. And when I first saw this, I was pretty scared, so you might also be. But I'll walk you through it. So in this Volcano plot, we compare the group of patients to controls. And on the x-axis, you can see the fold change. So if it's on this side, it means it's increased in ALD patients. And here it says more than 4 times increased in ALD patients. On the other side, it's decreased in ALD patients. So more than 4 times decreased here. And why do we use a logarithmic scale? Is because otherwise the graph would be really, really big. So on the y-axis, we see the p-value. And this is a value that tells us if it's actually true that there is a difference between the two groups. And the lower the number is, the more it seems reasonable that there's actually a difference. And this is also a logarithmic scale because it's otherwise would also be really too big. So we can see that there are quite a lot of lipids that are significantly different in the ALD group. And this is the new biomarker that we've been talking about, lyso-PC. So it's always nice when you have a positive control that comes out. We were happy to see that. But there are also some very interesting markers that were decreased in ALD patients. So what are we going to do next? What do you do with data like this? We got to repeat this. So this was the first experiment, but you got to do it again in independent samples, larger groups, and then keep on repeating it and see if the same things come out. And especially see if we can find markers that correlate with what we see on the outside.
Mostly phospholipids. Are you looking at other lipid species, glycosphingolipids?
Cholesterol as well, yeah. Yeah, this is just the first batch of data because you get an even more, it's a more technical part. Stefan knows a lot about this. But depending on what you do, how you instruct the machine, you get different kinds of results. So this was just the beginning, but we're expecting more, yeah. Yes.
I'll talk loud. Oh, I have a mic. Is the plan to correlate this with genotype? Is that like the eventual place?
No, not necessarily with genotype because there are so many mutations. So we're looking more to correlate it with disease. So does it correlate with the severity of your spinal cord disease, or does it predispose to having cerebral disease? That's what we're looking into. All right, so finally, the development of a clinical care pathway. We already talked about this a little bit yesterday, but for the people who weren't there, what is a clinical care pathway? It's a consensus statement by various experts on what the best clinical care is for a patient group. And we were actually asked by the Dutch Patient Association for Metabolic Disorders to make one for ALD. And the goals, obviously, for patients are to clarify the disease and the care process. For medical doctors, it helps to enable evidence-based treatment, and for health insurance companies, it helps to professionalize the care process. What is the outline? It starts with a brief description of the disease. Then there's a part about presentation. What kind of presentations could you expect in different age groups and in both men and women? What do you need to make the diagnosis, but also what could make the diagnosis difficult? So what are pitfalls? What do you have to keep in mind when you want to diagnose ALD? And of course, treatment and follow-up, which depends on what kinds of symptoms someone has. And it concludes with management, so which kind of healthcare professionals are included in the care for patients with ALD. And what kind of questions are we evaluating in the pathway? For instance, how do we evaluate the adrenal function? We know that a lot of boys and men with ALD get adrenal insufficiency, but what is the best way to evaluate this? And how often do you have to do that? And in our center, we've been having patients who had progressive white matter lesions, but who didn't have the typical gadolinium enhancement. What is the best treatment for these patients? And what actually are the best technical requirements that you need to assess gadolinium enhancement? Do you have to wait 3 minutes after administration, 5, 10, 15? What is best? I'll take you through a little example. So if we're looking at evaluating of the adrenal function, you can see a level here, and this summarizes the amount of scientific evidence there is. So level 1 would mean you have the best perfect evidence to be able to answer your question. And level 4 would mean there's no evidence, so it would be the opinion of experts. So here we can see it's a level 2, and this is about what kind of tests should we use to evaluate adrenal function. So if you read with me, it is likely that a high-dose corticotropin stimulation test, so that means that you get an IV, we give you a synthetic hormone, and we measure how much cortisol your body can make. The stimulation test is the first choice in evaluating the adrenal function in ALD patients with endocrinological symptoms. But if we then go to the next one, in the absence of scientific evidence, so level 4, the experts believe that basal morning cortisol and ACTH measurements are sufficient for the evaluation of the adrenal function in endocrinological asymptomatic male ALD patients. And this is interesting because this is what makes it really difficult. There is no scientific evidence. We know we have to evaluate the adrenal function somehow, but what is the best test? Should you keep on doing these stimulation tests? So we sat down in our center and we thought, okay, what do we think is best? Is it really necessary? And then we thought, well, if someone has no symptoms, then it's safe to just do the ACTH and the cortisol measurements. But as soon as something is not right, you have to do the stimulation testing. But this can really differ per center, per expert. And that's why we decided we have to take this to the next level. And of course, obviously, also because of the newborn screening, everybody is in the need for a guideline. And it is best if it's going to be an international guideline. So what kind of steps do we have to take with each other to get this, to get the best care? We start with the formation of a guideline expert panel. Then we make key questions per field of interest, so for instance, how to evaluate the adrenal function. Then per question, you look at the scientific evidence, you summarize it, and you make a recommendation. And then come the various consensus rounds. So you gather the experts, and you make sure that different international experts agree on the same recommendations. So you get the best clinical care. And obviously, in the end, you implement the final guideline. So this is something that is going to take a while because it's a lot of work, but I think it's really important for patients worldwide, and that we're in the need for this. And this is our team. Thank you so much. Questions?
The guidelines would address all stages of life.
Yes, yes. That would be the goal, yeah, to make it so complete possible. So also just for I think the newborns, when to start screening for MRI abnormalities, when to start screening for the adrenal problems, yeah.
I was just going to ask, has this work started yet, or what are the next steps to kind of forming the expert panel? And
yeah.
Obviously this is a great place to start.
Yes. So we started with making a Dutch version, and our patient association has like its own little format that they use for their clinical care pathways. But yeah, we're taking it up to the next level. So I think we have to do it better and yeah, include experts. But I think we're just in the first step. So formation of a expert panel. So anyone that's interested in joining.
Hi, I'll pass the mic over to, I don't want to, anyway, you said it'll take a long time, but like realistically, how long do you think this is going to take? Because I think there's maybe a similar effort happening in the United States, and it seems like, why are we all trying to reinvent the wheel here? Maybe we need to be talking to you and so.
Yeah, I think we should definitely work together on this, because the more we work together on one guideline, I think the faster it will go. It's not necessary to all try to invent the wheel.
You know, the other thing I was thinking, Irene, is probably will certainly be a phased, you know, continually updated kind of document, and maybe to start with, just you know, some of the analysis looking at the best evidence for screening, you know, for example, adrenal insufficiency and so on. in ALD may take a little time to understand what the best methods are. We may, may be the best thing to make an early determination on our best guess for now to be updated again in a year or 2 years in terms of timing. And so I think keeping the kind of the good and the better in mind may be helpful here too, just in terms of getting this out to the newborn screening efforts around the world.
Yeah, I think, you're right. We should.
Well, that was kind of my question, was what kind of time frame are you looking at? And would you publish or let ALD Connect put updates on the website like every 3 months, every 6 months or something like that?
I think that would be great to put updates. I'm not sure to give like a definite time frame, but I think we will be in contact with the experts that we'll be inviting, and then of course we already started with the Dutch care pathway, so we have a lot of key questions, and we have the groundwork has been done. So then it's just a matter of combining everyone and making sure that everything starts. Yeah.
And then a second part to my question. So the study that you're doing with the women that you brought back in, is that also going to be available for us to see?
Sorry?
The results of the women that you're bringing back in and rescreening, are you going to be able to allow us to see those results when they're ready?
Yes, of course. I'll be happy to. Yeah.
Thank you.
I'm just looking at the statistical aspects of things. Did you look at any further with your Volcano plot, like to do a principal component analysis or something like that? Your Volcano plot that was there. With
I tried. I was trying to go back, but I'll leave that. What kind of analysis?
Like a principal component analysis, which would pick up maybe a couple of those that are meaningful at once, or at least give you a couple dimensions, or show that your target is related to something pretty clearly.
So now it's like an untargeted test. But we didn't look into that yet. Like this is literally it takes pretty long for one experiment to go through the machine. So this is really just the first, very 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 first result.
Okay.
But thanks for the tip.
So I think this is wonderful, and I'm just wondering in terms of the clinical pathways, whether you're pulling in evidence-based medicine methodologists. In the U.S. we have resources like Up to Date and other online resources where people are constantly thinking about decision making. And then there's a whole movement, I think, in medicine now about integrated decision making with patients, and whether it's worth it to get ahead of that and actually start integrating patients into this process as well.
I think that actually would be a really good idea. We didn't think of that yet, but I think that we should do that, because you're right. It's shared decision making is something that is arising more and more, and I think we can already start like in the beginning, like when we're defining the key questions that we should see. Are we getting all the subjects that we want to include? So that would be a great idea. Yeah, totally agree. Yes, in the back.
In some case, patient HTH and stimulation test is normal, but they feel like adrenal insufficiency symptoms such as easy fatigue, or in that case, how do you manage the patient?
So fatigue is a really difficult symptom. We hear it a lot, even in the patients that have normal stimulation testing. And it's always the question, is this fatigue? It's very specific. So is it due to adrenal problems, or is it just due to having a chronic disease? Because if you have walking problems, that takes more effort. So that could also cause fatigue. But we really haven't gotten an exact grasp on what this fatigue is, but we know it is a severe complaint, and what we usually advise is to get a rehabilitation physician. Is that the English word? And to really see that how you can organize your life to deal with these kind of problems, and how you can make sure that you're not just putting all your energy into your work, but that you still have energy for other things that you would like to do. So more about organizing your life.
Okay. Don't you prescribe the steroid? No?
No, if it's a normal stimulation test, then we don't prescribe steroids. Any other questions? All right. Well, thank you very much.